Got my usual co-host here with me, Dr. John Hill, and welcoming back Tony Crino, who is our respiratory therapist from, let's see, clinical education coordinator at UHCMC. You need a shorter title, man.
Something like that.
Respiratory dude.
Yeah, clinical coordinator and education coordinator.
Yeah.
Kind of a combined role.
Yeah, we're going to, and most importantly for this audience, not only do you do the whole respiratory thing, but you're also a paramedic, and that is really why we needed and wanted you on here. And we want to cross that bridge. We want to cross that bridge to some of the stuff that you do in the hospital on the advanced ventilator side of the world,
Right.
and we want to kind of talk about how that can translate over and where we're missing stuff or where we could, better ourselves in the pre-hospital space. So all this month, hey, we got all of that out, but we'll do kind of a quick recap here. We'll do just a little bit of quick recap here in just a second for maybe those who haven't peeked in and watched, because we talked for a long time, and that is really for somebody who is, there's a lot of content there. Hopefully some of you that are really, really interested in it, took there was a lot there, so it's, I think, hopefully a good resource for anybody at least trying to get their head into the game. Is advanced ventilatory procedures right for our department or right for our clinical application? I honestly, I think that recorded very well. Hopefully somebody will take some away from that. So we're here in studio rather than live on the road. Due to some cancellations and stuff moving around, we got set up in here, and then on top of all that, we had a small flood over there in the corner. It's been some sort of a day. It's been some sort of a day here, almost as eventful as if we would have been off site. But we're here with you live from the studio. This is the first time we've been live from the studio in a year and a half. Yeah, so we'll get back out into the ether and out into the out with our departments again next month. So. That'll continue on. This just kind of worked for all of us today. So now, really, from the perspective of paramedic training, right? And I love that you can see both sides of this, right? We really kind of phone in and don't put a lot of emphasis on. It's just crash ventilatory stuff, right? We don't really get into the nuance of proper ventilatory management. It's even as an EMS educator myself, I'm bound by that educational curriculum and some of the stuff I have to teach in a particular way, and that is the stuff you fall back on. Like I said, it's crash stuff, right? Yeah. But this day and age, there is so much population, such a large respiratory population, that we were really kind of missing the boat on cases that were the middle ground, right? It's those edge cases that, a little bit of oxygen nasal cannula over here. There's really nothing to write home about. Requires intubation over here, right? Is that other far extreme, right? In the middle is where we can do a lot of good for a lot of patients,
right?
And one of those tools that is, I don't want to say becoming popular, but it's becoming a little bit more prevalent in high-performance EMS agencies, is some sort of advanced ventilator. So historically, ventilators in the EMS space have been relegated to very simple devices that essentially just are an automated BVM.
Right.
Could you talk a little bit about what kind of modes, what kind of features, what kind of things we can do in a small box now that we couldn't do even when you and I went to paramedic school, or even when John kind of started his career, stuff that's evolved since then.
Yeah. So obviously, with the advancements in technology that we have nowadays, we can do almost anything that we can do in hospital and on an ICU ventilator. Think of it kind of like how our heart monitors or our EKG devices evolved.
Have evolved, yeah. That's a great
We started
analogy.
off with a single lead that we could look at, and then we went to maybe 3 leads or 4 leads, and then now we're looking at 12 15.
And more, right? Yeah.
Right. Yeah. But obviously with that comes the education part of it. And if we don't know how to use the tool, it doesn't do us a whole lot of good. But so, when it comes to ventilators nowadays, well, I should backpedal a little bit and say, the ventilators that we used to use were very crude. They were pneumatic devices that didn't have a whole lot of control. If we were able to get anything less than 100% oxygen, we were lucky.
Yeah.
And we would maybe be able to set a respiratory rate or a minute ventilation. It was very crude. And on top of there just being crude settings, there was also not a whole lot of good integration with the patient, if you will.
Right.
So today's ventilators are able to sense what the patient is doing. They're able to adapt to how the patient wants to breathe if they are breathing on their own. So we have a lot more options out there.
Right.
We can do a lot more with them. So it used to be where we would predominantly use one mode of ventilation, volume control ventilation.
Yep.
Now we can choose between, well, some of our newer ventilators can have up to 10, 12 different modes of ventilation on there. So it's great to have, but at the same time we have to know how to use it.
Yeah.
So volume and pressure control, they still exist. It's just we have different ways that we can tinker little things here and there through different modes that make things a little bit more comfortable and appropriate for the patient.
Yeah, and I think that's a huge point, is the control vents that you're getting that breath at X rate and X volume, regardless of what you
like
need, whether you like it, whether you're on an inspiratory and expiratory phase. That alone, I think, is fairly huge, right? Is allowing some of that processing power of the machine to some of these newer machines to take over some of that, specifically for, again, we're focusing on the on the pre-hospital space. I understand as a respiratory professional, you want to control some of those things in some cases. In some cases, it makes sense to kind of let it adapt to what the patient's going to need and going to do. Because I know John, we've talked about this on numerous times on the podcast series. There are just some patients, like DKA is perfect example. Like, you don't want to intubate. We can't match with a BVM or a ventilator what their needs are.
Honestly,
any day of the week.
Any respiratory distress is just bad. Like,
sure.
I mean, we're even pounded into us that asthma exacerbations in kids are the absolute worst. You try everything you can not to intubate them because you can't meet that drive. And positive pressure versus negative pressure inspiration, it's totally different mechanisms, and then
different physiology.
Yeah, absolutely.
Yeah.
Different physics, right?
Yeah, 100%. But no, that's I think that's really the sales point, if you will, for why do we need this? Well, I've got a BVM. That's how I've always done it, right?
Sure.
But there is that middle ground, and some of the tools we have, the disposable CPAPs, or the CPAP boxes, if you will. Great step, but let's talk about that, because there's really two case uses here for the pre-hospital space, right? Sure. One is non-invasive ventilation, and we spoke at length that that's where the money's at, right? Preventing that intubation and letting the patient kind of dictate to the machine what their needs are, right? And then the other case use would be, all right, the patient is unwell enough, they had to be intubated, and now I can free up again, it's going to go back to the education thing, but we're going to free up some hands, we're going to free up some resources to make other improvements. You were talking about pharmacology here just a second ago, do all of those things. You still need to do all of those things in the background, right? It's not like, oh, I'm breathing for them, okay, everything's good. Well, no, we want to get them. Now, sadly, we had to intubate them or put an IG in or put an advanced airway, doesn't matter. We need to be working quickly to be able to, right, where clinically appropriate, walk them back off of that. But let's talk about that. Let's talk about that case use for the non-invasive first,
sure.
right? That's obviously the big one. So what do these bring to the equation that my consumable CPAP circuit over there lacks?
Yeah, so the ability to help them ventilate non-invasively, and I think that sounds like, okay, well, what does that mean? If we can avoid intubating somebody, we save both ourselves and the patient so much more trouble down the road,
Right.
if you will. With intubation, obviously you're going to have to sedate them unless they're, in full
Obtunded,
arrest,
yeah,
right. So we're going to have to sedate them, and what comes with sedation, sometimes a change in hemodynamics.
Yep.
So, that was a very, very tough thing for me to get over as a paramedic going into respiratory school. As a paramedic, I thought, we'll just intubate everybody. That's fine. If you're, even remotely able to be intubated, we're going to intubate you.
Why? Because they let me, right? It was that mentality, right?
I'm a hammer, that's a nail. Everything's a nail.
Right, exactly.
So that was a tough thing to get over, or a difficult thing, I should say, to get over initially.
Yeah.
But once you look at the long-term effects of intubating someone, we're intubating a lot of these folks, or we're putting them on respiratory support, not necessarily because they had some acute problem that just showed up today that hasn't been a problem. They have comorbidities, right?
They've been walking towards this for a long time.
Yeah. And if you take your chronic obstructive pulmonary disorder, your COPD patient that maybe is, in their 60s, 70 years old, and you decide, I'm going to intubate them in their living room, sedate them, probably paralyze them, and intubate them in their living room, that may be the last time they have in their lifetime to breathe on their own. We may never get that tube out because those folks with all those comorbidities are more difficult to extubate. They can be difficult to manage once they're on a ventilator. So non-invasive is really where it's at if you can safely do it. And I think the more agencies that we see embrace the idea of, hey, let's try them on some BiPAP, or non-invasive ventilation prior to jumping to intubation, I think the better outcomes that we'll see.
And that you set me up for the next point that I really wanted to kind of harp on is the CPAP versus BiPAP thing.
Sure.
So not a ton of out-of-hospital BiPAP going on, and I think that's a miss, right?
Absolutely.
There are very progressive departments that are doing it, right? It's not that it's completely lost. There's medical directors who clearly see the benefit and they want to, they're rolling towards it. But again, they have to have this investment in a tool that is, for the most part, there's some edge stuff that can be done in the bi-level space. I don't want to call it BiPAP for that particular tool I'm thinking of, but I think to do it most correctly with this tool, what's the advantage? Because the average provider is going to be like, well, their sats went up on the CPAP. What do I gain, and why should I care about pre-hospital CPAP or BiPAP? I'm sorry.
Yeah, so it depends on what we're trying to achieve ultimately, or what we think the end or the cause of the problem is. When we get called for shortness of breath, it could be anything, but there's certain disease pathologies or health issues that are going to cause certain problems. Just because they're short of breath. It could be one thing or the other. We can have a problem with oxygenation, or we can have a problem with CO2 retention, or we could have a problem with both.
Both, right.
But unfortunately, if we choose the wrong device, or choose the wrong mode, I should say, we can make things worse. So that's something that we have to differentiate. And when I'm teaching to our our nursing staff or our physicians, or even newer RTs, you have to make a differentiation. Is this an oxygenation problem, or is this a CO2 problem?
Ventilation problem. Yeah.
And if it's a CO2 problem, or if it involves CO2 in any aspect at all, like we have a problem with that, then BiPAP is going to be our answer, or non-invasive is going to be our answer. If we strictly have an oxygenation problem, CPAP is fine. But what we see with inappropriately putting someone on CPAP who also has a CO2 problem is we could end up retaining more CO2, and then we make things worse, and then where do we end up? We end up intubated.
Yeah, on the pre-hospital side of things, we see a nice pretty pulse ox, but in the background here's our end tidal.
Right.
And what are we doing? We're putting probably that mask over a nasal cannula. How sensitive is that cannula at this point? We may be none the wiser. We're not looking at ABGs. we're not looking at, right? So again, that goes back to your point. You have to know what your starting point is,
and that's the challenge in the field is, as a respiratory therapist, when I'm working in hospital, I have all of that.
All the tools,
I can
right?
draw blood gases all day long. I can ask the nurse to get a VBG, what have you. We don't use end-tidal CO2 in hospital as much as we do in the field, honestly. And there's certain reasons why we
use end-tidal CO2, but not in this. We use it for other things. We use it for like sedation.
So, right.
For that side of the world, not for this. We drive our changes for the ventilator based upon blood gases, not in.
Correct.
On the in-hospital side, right. Where we would exclusively have to do it with capnography on the out-of-hospital side of things.
So my last shift, I just intubated a patient. End tidal was 50s, I think, when we first put the tube in, and quickly came down appropriately. And talking to my RT, I'm like, hey, I don't think we need to be at 20 yet. And then the blood gas came back. I'm like, never mind. CO2 is actually like 90. Well, let's leave it there. He's like, that's what I thought.
I was waiting for a triple digits.
You were right.
And actually, I had a group of medics with me doing some teaching on Friday, and one of the points that we covered was, well, why don't we use in hospital end-tidal CO2 in our ICUs as much as we rely on blood gases? And the issue there is that the serum CO2 could be a lot higher than what we're actually seeing in our end-tidal CO2. So end-tidal CO2 is important, and we use it in the field. Yep. But that's because that's all we have.
It's the only tool we have, exactly.
Now, if we had a point-of-care system in the back of every squad to be able to draw blood gases,
stop it.
And
I don't want. I have a crew that has one.
He's working this whole angle. I'm sorry.
It's debatable whether they're reliable or not.
Yeah.
The units that are out now, and in the future they may get better, and that would be great. But ultimately in the field, that's all we have to work with right now is end-tidal CO2. But
well, the other thing to say about that is, like, how often are we getting blood gases in the hospital? Right? It's not Q5 minutes. It's not
right. Yeah.
It's not Q10 minutes.
Sure.
I don't work in an ICU, but I wouldn't even imagine Q30 minutes. Every hour we're going to recheck the blood gas and see how it's going. Right. We're setting our ventilator up to the parameters we want, and we're rechecking it every hour. Right.
Yeah. And in that aspect, end-tidal CO2 does help. If we can at least have a picture of what a blood gas looks like and our end-tidal CO2 at the same time, then we can say, all right, well, the serum CO2 was 80 and the end-tidal was 40. So we're going to say, and different disease pathologies present that way. So if you have someone who has a very poor diffusion capacity, and we can go on and on about this stuff, but you're going to see a huge difference in that. But at any rate, we can take that snapshot of ABG and we can take that snapshot of end-tidal CO2 and we can compare it later down the road. Yeah. But I think in pre-hospital, I think what we really need to make sure we're doing is getting a good history on these folks. So if you have someone who is, you're seeing them quite frequently for a CHF exacerbation. That's what happens every single time they call you. They ate a bunch of Kentucky Fried Chicken and they call you on Sunday night and they're it's the same problem every time, and that this is a oxygenation problem because of congestive heart failure, then more than likely CPAP is going to do great.
Is your tool,
but if this is your emphysema patient that you're seeing as a frequent flyer, or you walk in the house and it reeks of cigarettes, and it's clear by the tar on the walls that they've been doing this for a while.
There will be signs.
You can take a pretty good guess that their CO2 is probably going to be a problem as well. So I think having a good history helps you determine what mode you're going to end up on.
Yeah, that's awesome.
Well, I think that for our adult patients, 99.5% of them are going to be hypercarbic, right? When we're dealing with them. There's might be concomitant hypoxia, but they're going to have a hypercarbic component of it.
Yeah, potentially. And I think even if you have purely a oxygenation problem in the beginning, your congestive heart failure patient that's full of pulmonary edema, they may start off having only an oxygenation problem, but as that gets worse and worse, they're going to potentially have a CO2
problem as well. Yeah. And so the other kind of case use we were talking about is freeing up hands in that cardiac arrest and letting the machine do the work, because we all know that, and it's well understood and well studied, that we don't bag people well.
Correct.
Yeah. But again, this is going to go back to proper setup and training.
Sure.
We'll touch. Actually, we got some questions about training, so I think we're going to let the questions kind of answer the piece or get the message out about the training part. But your thoughts on bagging, human bagging patient versus a machine doing it?
Yeah, we're not good at it.
Yeah, it sucks.
Yeah, I mean, and that's a lot of that has to do with adrenaline at the time. Of course. But also we have no really good way of quantifying that of what we're doing. Now, some of the newer monitors that are out there on the market actually do show you your
volume,
delivered tidal volume, which is kind of great. But we don't know how to time things properly. We don't know how much volume we're actually squeezing with every breath. We also don't know what kind of pressure we're delivering when we're actually squeezing with an ambu bag. And you've got somebody screaming at you from the front of the truck saying, "Hey, we're 10 minutes away."
You're hitting bumps.
So there's a lot of distractions there to do it right.
A lot of variables.
But what that ends up doing is it impacts the patient's minute volume, which in turn, that has a lot to do with how the patient's ventilated. So the benefit of using a ventilator or even a non-invasive device is we can consistently maintain consistency.
Yeah, exactly.
Right. We could free up the personnel, but at the same time, we know we're giving them X amount of volume at X amount of rate. We know that we're and under X amount of pressure.
No, that's perfect. And with some of the other ventilator modes, let's say that cardiac arrest was we did our job. We shocked them back. They're in a perfusing rhythm, and now they have spontaneous respirations. Mm-hmm. They can breathe over that vent. They can do things. We can adapt better than, again, if we had the crude device that we spoke of initially, or us trying to bag them or match their inspiration, because that works exactly as advertised.
The synchrony aspect of it is huge, because if you aren't synchronizing with their spontaneous respirations, if you're fighting against the patient or the ventilator's fighting against the patient, one of the two, you can cause more harm than good.
You just selected it, so you might as well read it out loud. It's on screen.
Oh no, I didn't mean to. I was I was scrolling. I guess we're taking questions now because
Fantastic.
I was
all right.
honestly.
Lay them on us.
Should I go to the? Should I go to the other one that came? That's actually what I wanted to read. So apparently you have a fan.
Oh boy.
You have a fan.
You have multiple fans.
Hashtag more Tonys in this world is the.
Well, thank you.
All right. So let me. Actually, the same person here.
Well, there's also a Matt Conklin out there who called you the respiratory goat, and I asked him if he was a throat goat. But
that's
you didn't respond to me.
Hi, Matt.
So going back, what's your take? What's your take on EMS using high flow oxygen versus titrated O2 for COPD and CHF? A little off the ventilator topic, but let's play along.
Sure. So it's a great idea if you have the equipment to do it. It's a little bit of a challenge in the pre-hospital world if you don't have a heater and humidifier to accomplish something like that. But what we find in hospital is that our COPD exacerbation folks who don't tolerate non-invasive do fairly well on an Airvo device or a Vapothermo or any other high flow
oxygen.
Unit. Yeah. And it's nice because we can titrate the FiO2. We don't have to give them a tremendous amount of oxygen. In fact, some of the COPD exacerbations we've had have been on minimal oxygen, 24%, and we just run them at a higher flow rate. There have been studies in the past that have tried to figure out, is high-flow oxygen therapy or high-flow therapy a good alternative to non-invasive therapy? And what they were finding, at least in some of the studies I'd seen in the past, was that it really didn't do a whole lot to eliminate CO2, but it has helped to reduce the amount of CO2 that they're going to continue to build up. So in our ICUs, if we have a patient who won't tolerate non-invasive and we don't want to intubate them, we do have to come up with a compromise and say, all right, let's try some high flow therapy. We'll use a lower FiO2, a higher flow rate, and hopefully we can hold them over until the medication starts doing its thing or what have you. In the pre-hospital world, sure, if you can go that route, if you have the equipment to do it, that would be great. But just know that in the high flow equipment, if you're running at a higher FiO2, you're going to blow through oxygen fast, and that's something that is not a unlimited resource in the field. So
that it is not. It surely is a limited commodity. All right, do you think I can scroll through this without selecting everything again? Let me actually use the cursor here. Oh boy, people are chatty today. They want to talk to you.
Good deal.
What do you think paramedics? Let's see here. Let's bring that up here. What do you wish paramedics understood better about the role of respiratory therapist in the hospital from a continuity of care perspective?
That's a good question. I try and think of the paramedics that I've received report from as an RT. What did you do for them in the field, respiratory-wise? What drugs did you do? What drugs did you give them? Did you bag them? Did you put them on a vent? What kind of settings did you try? And did it work or did it not? How'd they tolerate it? Tell me a little bit about their history. I think a lot of the same information, at least from a respiratory standpoint, that the physician would want to know. I don't know if that answers the question or not.
No, it was teed up strictly as an opinion, so
okay.
there you go.
Well, and I'm asking those questions to share them with you because, again, we're having that discussion at bedside of what we think is going to be best for that patient at that time. And I tell all of my squads, too, like, if you gave Duanabs and now we're putting them either on non-invasive or invasive positive pressure ventilation, those don't count. We're going to start over from zero because I just want to push them farther on down into the tree.
Yeah, and I mean, one thing that I'm always making sure that I was passing off as a paramedic coming into an ER is, hey, what's my end tidal CO2? Since we're not using that as often in the hospital, I think it's good for the RT to have in the back of their mind that's the value that
it's a starting point. Yeah, it's something you can try to correlate to.
You come in and it says high, we're going to then anticipate that the patient's hypercarbic, right?
Sure.
If they come in low, it makes us thinking that not that CO2 couldn't be a problem, but it's less likely to be a problem, right?
Yeah, I mean, we talked on our capnography podcast. We talked about this ad nauseum, and I think the take-home point was, whatever that number is, it is at least that from a VBG or an ABG perspective. So it's at least that multiple variables that go into that. The patient's metabolism, their perfusion, their ventilation, as a broad brushstroke. But it's it's at least that, right? So they come in triple digits. That gas is coming back at least triple digits, right? Yeah, right. So, all right.
But if it's triple, if your end tidal CO2 is that high in a patient, like if we're talking 70s, 80s, 90s end tidal, I'm going to expect that patient's going to be hypercarbic and not responsive. I mean, that's super high. Not that we don't see patients that live at 70 on blood gases, but if they're coming in that high, they're probably not going to be responsive.
Or if they are, they're an old pro.
Yeah. I think that's the key. They've been there before.
They're not too upset about not too upset about that. Oh, yeah, what shift is today? Today is B shift. So we've got our Strongsville colleagues watching today. Here, let's talk to John. All right, so John asked, with the expansion of CPAP and end tidal CO2, is there data that correlates a decrease in field intubations by 911 responders? The expansion of CPAP, is there any data with us using more CPAP, is there data showing that we're intubating less? Anecdotally?
Yes.
Anecdotally, I know that, right?
Yeah, I personally don't know the data on that, but I would make the assumption that that's the case.
Yeah, it's definitely there. I mean, from the first 10 years of my career to the last 20 years, there's just been a drastic swing in how much PVC gets distributed.
Well, I mean, if we start someone earlier in the field on positive pressure ventilation with CPAP, that might be the difference between me discharging from the ER,
versus,
right? Because I worked this weekend. I had a lot of respiratory calls, and the question is, we got a respiratory distress coming in. Respiratory therapy is coming down. They're bringing BiPAP with them. I'm like, well, did EMS put them on CPAP? No, they didn't say so. I'm like, oh, man. Like, do that one thing.
Yeah.
And one of the ones over the weekend was we put him on CPAP when he arrived. His end tidal was a little bit, his venous blood gas show he was retaining CO2. I was able to take him off BiPAP. He still got admitted. He still was, but yeah, I was able to take him that way. So it can make a big difference.
Yeah, and we're talking, this is a pretty, go ahead.
I don't. So apparently, this person likes you, but doesn't like me, because then I've got Scott aging himself again. This is.
No, I mean, the CPAP machines that we have, even the archaic yellow ones that smush on, it's a fairly easy intervention that that could prevent a lot of problems.
But a basic EMT can do that, right?
Yeah.
You don't
That's
need
huge,
to be an advanced.
right?
You don't need to be a paramedic.
Right.
You just have it's a basic skill. That makes a world of difference.
All right, kind of dovetailing back to the advanced ventilator piece here. What is the minimum level of training you think a provider should have before managing an advanced ventilator in the field? So let's frame that in, I think this would be additional education, because we're already kind of boxed in by scope of practice in the state of Ohio, where a paramedic would have to do said techniques, right? This is so. What do you think? Additional training in the whatever device they've chosen, right?
Yeah, I mean, that's a tough question to really put a solid answer to.
Sure.
But there needs to be some. Let's just say. There has to be something. The classes that I put on for our medics that come down to CMC, they're about 4 hours long, and I preface all of that information with, look, the respiratory therapist who's managing the ventilator in the hospital has a minimum of 2 years of ventilator training before they're on the streets and in the hospital managing these things.
Sure.
It's impossible to cover all of ventilator management in 4 hours. That being said, though, we have to look at what's practical. So, a good 4 or 8 hours, I think, is a good place to start. But the important part after that is there needs to be follow-up. And what I stress to the folks who come through my training program is that this is fine, and you can learn some today, but you need to continue to learn. If you've got one of these vents sitting at your base or at your station, you've got to practice with it. You have to. Take it out, play with it, even if you got to take a glove and put it on the end and tape it so you have a test lung to work with it. Do it, because the only way that you're going to maintain some sort of competency is to use it regularly.
Yeah, you have to have that knobology. You have to know how it works and what knob does what and when to do those things.
Right.
And you got to sometimes get used to just turning that knob and setting that setting.
Yeah.
That's the mechanics of it, right?
Yeah.
That's the operational part of it. But then there is, what does that knob turn translate into?
Yeah, the
physiology
right,
exactly
right.
is the huge part. And I think so many people focus on, they think they have enough of the physiology. Again, this is just, I'm kind of going back to my experience being a paramedic. Oh, I know respiratory physiology, and then starting to use vents, like, maybe I don't know respiratory physiology all that well, right? And then learning, again, a lot of that was self-taught, and a lot of that was, seeking knowledge. And there's a lot of good, in the critical care space, there's a lot of good training that, is crawl, walk, run kind of stuff in that ventilator physiology and getting you squared away. But I think that goes back, and this is a huge point, you need something, and whoever, if you're pulling this trigger at your department, you need to understand the culture of your department.
Right.
Is this something that you're going to have to force down a lot of a lot of throats and to have some minimum competency, or is this something, do you have the guys and the gals that are just yearning for information that are going to do exactly that, right? Is they're going to do their rig check and they're going to pull this out, and then they're going to run a couple sample scenarios, build that into their, build that into their training for the week or for the day or whatever, right? But yeah, no, absolutely, and it's never ending. I guess that's the other part of it is
it's not. And even when you get comfortable, I think you're going to come across a case that gets
100%, absolutely.
My last intubation, it's fresh in my mind because it happened a few days ago. It's a sick guy, sedated and intubated him, and next blood pressure is just in the toilet.
Yeah.
Now, is that probably because of the drugs? But it's also probably because I'm now pushing air into his system.
Yeah, could be, right.
I've taken kind of control of that, and now I have to throw on more drugs, and now we're putting him head down, which is not ideal for an intubated patient, right? But it's what I can do in the moment before I get my pressures up and start to manage this all together. And now, I was going to now hang propofol, but no, I'm going to switch from propofol. I'm now going to go to Precedex because I don't want to affect his blood pressure even more by driving lower propofol. And not what I was expecting, but okay, well, this changes my plan from what I was set forth to do, and now we're doing something totally different.
Yeah, and you have to be able to adapt to those changes. And, when we think back about what the term paramedic means, just at baseline, it means mini medic or kind of medic, right? So just because we have a heart monitor and we do 12 leads doesn't make us a cardiologist.
Yeah.
And just because we have a ventilator doesn't make us a pulmonologist or a respiratory therapist. So, there does need to be some additional training. There has to be. But at the same time, we can't expect the paramedic who's running a ventilator in the field to be a respiratory therapist or a pulmonologist, just like we wouldn't expect them to be a cardiologist with a heart monitor.
Yeah.
So.
All right. And did you hear us talking? It's my understanding that City of Cleveland is actually putting advanced ventilators in their
I didn't.
their regular.
So I was in one of my departments this morning, and I said, "Hey, we're going to be live talking about ventilators." And the question from the crew was like, "When are we getting those?" I'm like, "We can talk about it whenever you want."
Yeah.
And it's going to be probably those apartments that have ventilators in their area, right? If you've got a nursing home or some other advanced level of care, whether that's a long-term care facility that has ventilators, it might be worthwhile to invest in a ventilator, invest in training and know how to do it, or even to the point where you get called like, "Oh, I know this problem. Let's suction out their trachea. Let's replace that cannula," and everything's all better. Doesn't even need to move. Patients fixed in place. Don't even need to be transported.
No, absolutely. I mean, just with that knowledge from running them on my own, I've absolutely had calls where I've walked in and be like, "Those are incompatible with that human being." Let's do some things, right? Let's put them on ours for a minute. Oh, look, they got better. Well, maybe it's just these settings, right? But no, and I think that's an amazing step. And we were talking, like, even with their relatively short transport times, I think that's a huge move, and I'm anxious to see what comes out. I hope that information I have is wholly correct, but I believe it to be so.
Yeah, I think the importance is that great, we're going to use it as a ventilator, but I think the ability for non-invasive ventilation.
That's what I'm interested to see is how they're going to.
They'll probably get more use out of that.
Absolutely. I would expect. Yeah. I'm really intrigued to see how that plays out.
Yeah.
So getting into some more ventilator proper stuff. See, Fire Dude says, which ventilator alarm should a new provider absolutely understand on day one? And how should they respond? Silence button, right? You just
I always tell everybody that's the most important button.
Just keep turning it off, right?
Yeah. No,
clearly not, right?
I can't say that there's just one important alarm. I think there's a few of them. Number one is your pressure alarms. And the caveat to this is that those alarms have to be set appropriately, because if they're not set appropriately, it doesn't do you much good, right? So
same thing a monitor, right?
Yeah, right. So high pressure alarm is important to pay attention to, because if we overpressurize somebody's lungs, we're going to potentially blow a pneumo and cause more problems for ourselves. And then also low tidal volume, low minute volume. Those are probably the three top most important ones. So we need to make sure that we're not over pressurizing somebody, and we also need to make sure that we're giving the breaths that we are programming the ventilator to do.
No, I think that's good. And kind of tagging on with that, this person they got a lot of questions today. This is awesome. Again, they ask, what simple troubleshooting framework would you teach a beginner who feels overwhelmed by alarms?
Look at your patient.
The silence button.
Yeah, the silence button. Yeah. No, look at your patient first. Start there, and then work your way back. There's obviously a lot of things that can cause alarms, and we don't have all the time to talk about that. But making sure they're set appropriately is the number one thing. And what our protocol in hospital is that we set our alarms double above or half below what the patient's actually doing. And that's just a baseline. We can vary from that. We should vary from that to tune it per patient. But as long as they're set appropriately, then we need to find out what the ventilator alarm is or what the alarm is, and then figure out how to fix it. So if it's a high pressure alarm, there's all sorts of different things that can cause that. But we start looking at anything that the ventilator would experience as it's trying to blow the air in that would cause the pressures to spike. So we think about kinked off tubing. We think about a patient that maybe is biting down on their ET tube, or perhaps they coughed up a big mucus plug into the tube. And then we start thinking about, maybe they're having bronchospasm and their airway pressures are now going up. So we have to look at the alarm and then try and diagnose from there. And then we can continue on and on with that. Low minute ventilation is the same as not getting enough air that they're supposed to in a minute. And in that case, we could have a leak going, the circuit could be open somewhere. We could also have a problem with the kinked tubing that the air is not getting in. So, of course, we're not ventilating them the way that they're supposed to. So you kind of have to take each alarm and, say, okay, with this particular alarm, here are your potential causes. And kind of break it down from there. But initially, when you put that ventilator on the patient, you're going to get a whole bunch of alarms right off the rip. That's just how they all operate. A lot of the newer ventilators operate on a pressure-regulated volume control algorithm. So what they do is they start delivering pressures, low pressures to a patient to try and achieve the certain amount of breath size that you dictated in your settings.
Ask it for you.
So initially the pressure's low, and what that results is usually low tidal volumes or low breath size, and then low minute volume, or the amount of air that they're supposed to get in a minute is lower than what your alarm threshold is. So you get a lot of alarms initially when you first put them in, or put the patient on the ventilator. So you kind of have to give them a second to settle in, and then reevaluate in 30 seconds to a minute, while knowing where the alarm silence button is. And also, obviously, you're going to look at your patient, too. Look at your patient. If they're turning blue, you need to make some changes, right? Take them off and bag them if you're...
Correct.
That's probably the first... if all else fails, take them off the vent and bag.
Right, absolutely, yeah. So give them a second to settle in, but you have to have a good understanding of what the alarms mean before you can start diagnosing things.
Yeah, I think that's huge, is understanding why.
Yeah.
They're not happening in isolation. Right. There's a reason. But all right, where was this other one that I thought this was great here? There we go. No, this is not cooperating. That is here. I just gotta scroll back. There we go. All right. What respiratory technology or treatment do you wish paramedics had access to in the field? What do you miss the most in your paramedic job that you have?
Non-invasive ventilation. I'm being 100% honest here.
Yeah.
Like the amount of times I've been in the back of a squad and thought,
I would put this patient.
Dang, if I could put this patient on BiPAP right now, this is what I would do. Or a blood gas machine, or a chest X-ray. There's a lot of, those things obviously we can't have that easily. But non-invasive, that is something that is really, really. I think we're behind the ball there. We should have already had that in the field. Hopefully, we'll see more out there.
And then this is kind of a general ventilator question from our house mom over there. So, as a mom of a 6-month-old who was intubated for 4 days from a virus, are there any long-term concerns? And will he be more susceptible to more severe reactions to viruses in the future? So I think one question for both of you there.
Yeah, so I will preface this in saying that I am a adult-only respiratory therapist. We have a whole separate PEDS education coordinator. But a 4-day intubation, as long as it wasn't traumatic, should not be anything to be too concerned with. You know, I wouldn't consider that as something that's a life-altering event.
And same for me. I mean, I was personally intubated for almost, I'd have to look back, but around 3 weeks I was intubated for. Hasn't slowed me down too much, so I think I'll be okay.
Yeah.
But again, yeah, trauma is the biggest thing that we kind of worry about with those intubations, and obviously causing that trauma causes blood to get in that airway, makes it a terrible airway to work with, and then it can obscure your view, can cause some scarring, right? And then causes swelling, which is really super bad when we're talking about airways.
Yeah.
I want to not have any edema back there.
Sure, and either there's caveats to the being intubated for 4 days. If the person who was operating the ventilator didn't know what they were doing and were using super high pressures for a long period of time, you could have some issues. But generally speaking, I don't think that's an issue.
I think it's worth saying that, especially now, and I had the conversation with another patient that we intubated at my shop and sent out, is like how we treat these patients, especially with like ARDSNet and everything and acute respiratory distress syndrome. I think that we all now, and the training is like as minimal volumes as possible and to not stress the lungs out. And we know how kind of fragile that they are, and aiming towards those lower volumes, lower pressures.
Yeah, and that's something that we use actually. It's our protocol for ventilation in the hospital. 6 to 8 milliliters per kilo of ideal body weight.
Yep.
And that's what we teach all of our transport teams, and any medic that comes through my class, they're going to get the same protocol handed to them. You obviously have to go by the protocols of your agency that you're with, but 6 to 8 cc's or milliliters, we have to say nowadays, of ideal body weight, and that's the big thing. So you've got to calculate their ideal body weight. Most of our RTs at our hospital, they all carry a little chart on the back of their badge that says male, female, their height, and predicted body weight, and even the tidal volumes for those particular ranges. You know, when we're so serious about that in our ICUs, it is not uncommon for us to break out a tape measure and say, okay, Granny is this tall, and this is exactly what her tidal volume should be. And of course, maybe we're splitting hairs there, but it's for the protection of the patient.
Are you?
Very similar.
Yeah, I mean, are you really? I mean, these are on all our critical care trucks just for that, and aircraft just for that reason, right?
That's great. Yeah.
I mean,
and not only are we monitoring tidal volumes, but to the intubation aspect of that, we're actually monitoring cuff pressures. That was something that years ago respiratory therapists used to do with all of their rounds, and then we kind of tended to get away from that. But recently, there's been a comeback where every single round or every single patient that we're seeing, at least once a shift, we're going in there with a pressure gauge, and we're measuring the ET tube cuff pressure or the tracheostomy cuff pressure, because you can cause a tremendous amount of damage to the airway if they're intubated for even just a day or so with higher pressures.
And that you hit a kind of a pet peeve of mine. Because, what does EMS know in an adult patient, right? What do you fill the cuff with? 10 milliliters, right? It's the whole thing, right?
Exactly.
It's not the right answer.
It's still not the right answer, right? We go through a lot in the absence of a proper manometer. Those, I don't think we have one in here, but the small digital ones.
Cuff fill syringe.
Cuff fill, thank you, Cuff fill AG, they're not terribly expensive if the department wanted to buy one and get the proper pressure of $50, $60, something like that. And, we're at least teaching now cuff to seal, just enough to get a proper seal, and then let you guys tune it when you get to the hospital, but better than
slamming the whole thing.
Slamming the whole
right,
thing.
And the old practice in the beginning of respiratory care was minimal leak technique. That's what we called it, MLT. So, and that's how we would document it all. But we would put the air in the cuff until when you bagged, you didn't hear any leak, and then you took a tiny, tiny little bit of air out until you heard a little bit of leak, and that was it. That was it. So, but what they're finding is actually measuring the actual pressure is much more effective.
Of
than
course,
using MLT.
yeah. One's subjective, one's objective.
Sure.
Yeah, of course, it makes complete sense, right?
Yeah.
So, all right. Okay.
I'm still okay from a ED standpoint. Like best practice, absolutely, right? If you've got a manometer you can measure, beautiful. If not, cuff to seal, you can feel the pressure on it.
Yeah, and
if it's rock hard, you've done it wrong.
Right. And actually, that's been studied. It's been studied comparing actual numerical values of cuff pressures with the experienced respiratory therapists squeezing on a pilot balloon. And what they found at the time, and this is changed but what they found was that there wasn't a whole lot of difference between if you had a seasoned RT who was squeezing on the pilot balloon and someone who was recording the actual numerical value. They were pretty darn close if you had somebody who had some experience.
Right.
But again, objective versus subjective. So.
But that also comes with the experience of dealing with hundreds and thousands of
patients. And if you're
patients,
in the field, is it going to hurt anything to have an overinflated cuff for a 20-minute transport time to the ER where the cuff can be checked by the respiratory therapist? Probably not.
I would suggest let's not find out.
Yeah.
Don't slam 10 mLs of air into it.
If you're getting a running start, you're doing it wrong.
Don't Happy Gilmore it.
Exactly.
But if it's giving anyone any anxiety over, I don't have a cuff fill syringe, what am I supposed to do? Well, fill it up to where it feels somewhat firm.
Taut,
and that will be just fine as long as it's not leaking.
All right, we're kind of getting up on the hour here already, and we haven't washed away, so our flood's moderately controlled. Our dam over there apparently is working. Let's see if we can get these last two in. Oh, these are good. Let's do this one first. That's pretty good. How do you recommend a novice difference? Goes back to your ventilator alarms. How do you recommend a novice differentiate between a patient problem, like a bronchospastic event, and a ventilator problem, like a high-pressure alarm? I guess they're both patient problems, but how?
Well, they don't necessarily have to be patient problems, but you got to look at both. I guess you start with one and try and troubleshoot, really, and that's the same thing that I'm going to do with 16 years as an RT of experience. Going to look at one and see if that's the problem, and you try and tackle the easy stuff first. High pressure alarm, for example, look really quick with your eyes. Do you see anything kinking off the tubing? You can get into looking at ventilator waveforms, which some of the transport teams or agencies out there are using ventilators that have waveforms, and that can sort of help. But really, you have to be able to understand what causes the alarms in the first place, and then decide, okay, what's the most critical thing here and the simplest to fix, and then we start working our way out from there. So again, it's not a clear-cut, real good answer, but you kind of have to just look at things quickly and choose, am I looking at the patient first or am I looking at the ventilator first? And there's other things that are going to play into it, your vital signs, how the patient actually looks. That's going to differentiate, do I tinker with the machine or do I just try and do something with the patient?
Awesome. All right, let's see here. And this kind of goes back to the novice user. I'm glad they're taking this approach. This is great. In terms of safety, what are the top red flag mistakes novices make that can immediately compromise a patient?
Choosing the wrong mode would probably be the number one thing. All of these ventilators, they have controlled ventilation, which the ventilator will do 99% of the work for the patient, if not all of it. And then they have spontaneous modes available. If you use the wrong mode, you're going to be in a lick of trouble. And then also not using the appropriate tidal volumes one way or the other. So if we're not ventilating them enough or we're over-ventilating them, we're going to cause problems as well. So I think that's why it's a really good idea to have a general idea in your mind of what kind of size breaths your patient should be getting. So if I was to initiate ventilation in the field on someone, one of the first things I'm doing is sizing them up from a height standpoint.
Yeah.
And okay, granted, I've got 16 years as an RT experience. I could look at somebody and say, you're probably a 450 to 500 person. Maybe you're a 500 to 550 person just based on your height. And I can choose a general tidal volume. But if I put you on the ventilator and I'm not paying attention to the tidal volumes that are returning, or if I'm not paying attention perhaps to pressures that are achieving, I can really do a lot of damage. Yeah. So knowing what settings you should see out of the person or what values you should see is important. But understanding how your settings affect other potential values, like, okay, if I use this type of tidal volume, I should probably see consistently this pressure. Yeah. And if I see my pressure start to creep up, then I know that there's a problem. But it's one thing to be able to take a protocol, open a book, and say, okay, based on this height, I'm going to use this tidal volume.
Yeah, right.
That's fine. But what happens if you don't know anything else about how the machine is working or the physiology behind it? If you don't understand the relationship between volumes and pressures, then you're going to have a really tough time. And you're going to show up somewhere, and another person who does know is going to look at you like, dude, your tidal volume of 500 is generating pressures of 45. What's going on here?
Yeah.
And so I think not choosing the right mode is probably one of the biggest mistakes, and then not monitoring values appropriately would be the second mistake.
Garbage settings on your alarms and whatnot. Yeah. So, again, I just want to reiterate that it can be a super useful tool, but we'll go back to the education package. This isn't something you spend your grant money on, throw it on the truck, and tell your crews to go be awesome. Yeah. It like everything, comes with benefit, comes with risk, right?
Sure.
You have to know no, man, I think we've some great involvement here. We've had some great questions. John, did you see any I missed? I think I got all of them.
I don't know if you did this one. How about this? How does your approach to area management differ from what we do in the field, meaning paramedics, I'm guessing?
It's a lot of the same. I mean, honestly, it really is. The only difference really is that I have more diagnostic tools.
You're probably in a better lit room.
Yeah,
with more tools.
Right. Well,
more hands.
Yes, yes and no. But I think given in hospital, given my experience in both worlds, one has complemented the other, right? So I've learned to intubate somebody on the beach when the sun is glaring and I can't see the screen of my air track or whatever I'm using. I've learned to operate in a way that if bad things come my way or things don't go the way that I want, then I can adapt and overcome that issue. Right. But in hospital, unfortunately, some of the folks that are working in there have never been in a poorly lit room or crammed in between the toilet
and the bathtub.
Proverbially.
Sure. Mm-hmm.
So, so we're doing a lot of the same things. It's just we have a more controlled environment to do it in, and we have a lot more diagnostic tools. So if I think I hear stridor, okay, well, we're going to shoot a chest film or not a chest film, but a X-ray of the neck. I'm going to take a look at things. Mm-hmm. Oh, it looks like everything's kind of good. Maybe they'll go to CT, what have you. We're going to draw blood gases, and we're going to find out what the actual problem is. I have the ER doc that's going to tell me, oh, no, we have a history of X, Y, and Z, and then I can put all the pieces together. So, unfortunately, in the field airway management, we have to do a little more sleuthing on our own and using our experience and our brains to figure things out. So.
Now, was there anything else I missed? That was the only one I missed? All right. We've kind of run up on our hour here. Tony, man, this has been absolutely great. Certainly something that I wanted to do and then kind of, hopefully get some wheels turning for some providers. And I knew you were the guy to do it. So, man, I can't tell you how much I appreciate you coming on, and this has been absolutely fabulous. John, anything from you? Parting words? This is.
Nope. The only thing I want to say, because we missed it at the top of the show because we're out of our normal element, is all the show notes, videos, audio is all available on our website, prehospitalparadigm.com. We've got our education website up as well, so you can get an hour of CE, free Ohio CE for this, and all of our prior podcasts are up. We are working on very diligently on getting CAPC credits up and running, so that'll be coming as well, and hoping for 2026 when that comes out, and you'll be able to get full credit for this. And we'll probably have some more offerings from our Prehospital Paradigm podcast website from an education standpoint, that when we get CAPC credits up and going, it's going to likely give you access to all of the other education we do from inside us. So
inside UH.
Inside UH. So we every month we put on 2 to 3 hours, 2 hours of education. We're going to move that into this as well.
Into this platform as well.
So that way, if you're in Illinois or not in Ohio, you can get the same training that we do here in part of the UH family. So that's what's coming up around the corner. Thanks again for coming. You're smarter when it comes to me and all of this. So glad I don't have to answer all the questions. So
thanks.
Thanks.
Well, thank y'all. Okay, catch you next time.
Thank you.